All right, 7:01, so I'll get started. Good evening, everyone, and welcome to the Northwestern Melbourne Primary Health Network session on supporting clients affected by female genital cutting and circumcision. My name is Claire, and I'm part of the workforce development team here at the PHN and will be facilitating the session today. Before we begin, I'd like to make an acknowledgement of country. The Northwestern Melbourne Primary Health Network would like to acknowledge the peoples of the Kulin Nation as the traditional custodians of the land on which we're meeting today. We recognise their continuing connection to the land and the waters and culture, and like to pay our respects to their elders past, present and emerging. We will be hearing from a range of speakers today, and I know I'm very grateful to have all of you here and to share your expertise in this area and going into a bit of a deep dive on what resources and will be available. I do have a brief housekeeping to touch on before we start. All the participants are muted for the duration of the session, but we will be using the chat for some interactive questions and asking comments during the session. If you do have any questions, we do ask if you could use the Q&A function. That helps us monitor the questions and make sure that they're answered. The session is being recorded, and all questions and chat will be kept anonymous for your privacy. We also ask that the Zoom, the name in the Zoom webinar is correct. This helps with marking attendance, and that we can send you an attendance certificate at the end of the session. If it is different to the one that you registered with, you can send a message in Zoom to the Northwestern Melbourne Education account. I also just wanted to briefly highlight the health pathways. We will have our clinical editor, Dr. Ella Elwood-Shoe-Smith, touch on a bit further about this. Dr. Ella is also a GP in Brunswick and will be able to discuss a bit more specifically of the pathway that we'll be touching on. There is over 850 pathways for GPs to use the point of care. Oh, my apologies. Now I'd like to introduce our speakers for today. We have Dr. Sarah Whitburn, who's a general practitioner and medical educator at Family Planning Victoria. She's also a fellow of the Royal Australian College of General Practice and is passionate about quality sexual and reproductive health care throughout a person's life. Thank you for joining us, Sarah. We have also Nigisti, who's a nurse, midwife and social worker and is the Family and Reproductive Rights Education Program Coordinator at the Royal Women's Hospital. Thank you as well. And we also have Mari, who's a registered nurse and midwife and nurse immuniser, and is the Associate Nurse / Midwife Unit Manager at the Women's Health Clinics and African Women's Clinic at the Royal Women's Hospital, Melbourne. Thank you all for being here today, and we're really looking forward to hearing your presentation. So now I'll hand over to Nigisti to lead us into the session.
Thank you. I'll share my slide first. There you go. Share. Thank you very much for that. Good evening, everybody. I'll just organize my slide. Yeah. Right. Thank you very much for giving us the opportunity to speak and discuss female genital mutilation, which is an important public health issue. First of all, before I start to talk about our program, I would like to acknowledge, the GPs of Victoria for the last more than 20 years who have been involved in supporting women who are affected by female genital cutting has been a major role. And they have taken in adapting to the issues in managing and referring them. So I would like to acknowledge those senior GPs in that. Now I would like to talk to you first about the program I'm coordinating. This is in short, FARAP. The name is a long name, which is trying to cover, not to say female genital cutting, but to put it into the perspective of sexual and reproductive health issues. So the program started 1997. Not only in Victoria, it was a federal program with the issue starting to rise in surface Australia-wide. I think I'll take you back how we happened to see these cases. In the early 80s, when I came, there were no issues of this, but by mid-1990s, there was a program called Rescuing Women at Risk. So those women who were in the Horn of Africa and refugee camps were in a bigger problem, and there was a big lobby, and thanks to Australian government, they brought massive number of them. And as these women arrived, they came with many of their children, pregnant, some married, but many of them with no partners. And that was the time this issue arrived at the hospitals, at Royal Women's Hospital and in Dandenong. And when the first, female genital mutilation, or I'll talk about the definition later, but when the closed vulva was seen during labor, that was the biggest surprise and shock to medical service providers, and that leaked to media, and media took it out and said this barbaric community came and they saw their vulva and there was no way they were going to have babies out, so there should be a law passed. At that time, of course, the laws prepared, proposed, and mandatory laws passed to stop this practice from happening. At this time, the community rose up and they said, we are grateful you brought us for peace and freedom to your country, but we don't want you to abuse our culture. Then the government stepped back and said, well, if we're going to eliminate this practice by law, then we have to have a support of the community. Then they consulted the community, and what was needed was education, information, support the women who are affected already by the practice, and stop the practice from happening to the new arrivals. So this program started, and within the community, they selected many women who spoke the language of the community, because at that stage, many of the community didn't speak English. To support them, they selected this woman, and there was one man in Victoria, I think they had 15 of them. They trained them in sexual reproductive health and also in health promotion. Then the program started from there on. I think the federal funding stopped in the other states, but the Victorian government had vision. Still, this program continues for more than 20 years. So I'll stop there. And the role of this program is really to inform, educate, raise awareness, and change the attitudes of the community to abandon the issue. And also for those women who are affected, to support them and receive timely service. And also, promote the cultural understanding of the issue with service providers. And finally, it's to end the practice itself. Well, what's female genital mutilation? It's a total removal of the external female genitalia or any other injury to the female external genital for non-medical reasons. It is done for cultural reasons only, which is inappropriate cultural reason. For those lists as issue, we'll discuss them later on. And that's the only reason why it's done. I'll talk to you a little bit about its, the practice, cultural background, historical background. We have no written document to say, this has happened, but we know many communities over thousands of years have been practicing it. And obviously also the practice of clitoridectomy has been in the West until 1970s. The background of this issue has caused so much issues. Currently, it's estimated that about 200 million women and girls are affected by this practice. This happens in many communities in different areas of the world. But most importantly, in Australia, when we see these women, most of them we have seen have come from Sahel part of Africa. But this woman has come through other traumas. FGM is not an issue for them, but it is an issue hidden because of their experience. As I said before, they have been in refugee camps, abused, even up to sexually harassed and raped. So they have so many other baggage with them. And this practice is not confined to Muslim communities. It's practiced by non-Muslim, Christians, and by everyone. And it also affects women who are educated or who have come from village. It doesn't discriminate anyone. So even recently we had a woman who have a medical degree. So we have to understand that. If we look into the practice or the prevalence in Victoria, obviously we don't have exact written number because it's not documented, as I said, but we know there are over 34,000 people living in Victoria from countries who practice FGM. But that's including men, women, and also like many others who don't practice. But that's the estimate. But the largest settlement of this group we had, it has been the Horn of Africans. But recently also we are seeing many of West Africans also. And also, you know, the practice prevalence in each country differs very widely and variedly. Some countries might practice up to 27%, but some of them will practice up to 98% of the women had gone through this practice. But there is little evidence in practice here in Australia or in Victoria, I'm saying. We couldn't, I mean, obviously you would have heard there was a case in New South Wales about over a year ago. There was a prosecution, an Indian community member with the help of a retired midwife have taken 2 of her younger daughters, age 7 or 9, and they had the practice done when they were told not to mention it, but when they went back to school, the youngest one informed school and they got in trouble. And with the mother and the assisting retired nurse, they were in home detention for a year. And there was an involvement of the imam who tried to cover, you know, this was a blessing. Nothing was done in that. He got a year imprisonment, but later on it was quashed. So recently we have heard in Queensland there is a pending case, but we don't know the evidence. But we have seen recently even girls who are born in Australia. I think we had a case recently with a 28-year-old young woman who is born in Victoria. She's been taken to country of origin and she had the practice done when she was younger. This could have been before the law was passed, but we don't know. And obviously we had one from New South Wales recently who presented to us. She said her family had taken her to one of the Arabian countries and the practice has been done to her in a clinic by a white woman, as she describes it. So we can't say there is nothing totally. So we need to continue the education, reminding and that. So here, this map shows us, you know, where the practice is. Mainly, as I said earlier, we used to have them all from Horn of Africa, but we can see also where it's spread. It shows the proportion, as you can see in the map, from the Sahel belt of Africa, west to east, it's all done, but nothing seems to happen further north or south. So that's the UNICEF map showing us that. Obviously, the reason it's done is it's nothing to do with medical issue, it's traditional, and it's seen as a passage to womanhood. And also they do believe it's cleanliness, hygienic, increased fertility and child survival. They do believe, you know, it's a myth, but they do believe they will have miscarriage if they are not closed. They do believe, you know, the child might touch the clitoris when it's born and it will die. So there are so many myths following this. And also some do believe really it's some, you know, cultural identity and it's, you know, that sort of following, and beauty is mentioned. And like some of, I think one young woman recently, which she said, my mom and dad didn't want me to have it. They knew the pain. But when I was with my friends were laughing at me. They were calling me a girl with a third leg. So I wanted to be like them. And I begged and had it done. But look, now I regret it. So that cultural identity is really amazingly important for them. And so also they did believe, girls wouldn't be straying away. They will keep virgin before marriage, and within marriage also there will be no infidelity. So that's a major issue. And also some did believe till recently, it's a religious observance, but they have refuted it, and imams and also Christian leaders, they have gone through books and they didn't find any evidence. So there is no requirement of that. And obviously, this practice is carried mostly by older women who had been practicing this job inherited from a family tradition. But in some areas like Nigeria, some men do it, but it's rare. But these women have no obvious training. They have no medical training. They use any instrument you see on the other side of it. It's not sterile. There is no anesthetic. And with no medical training, obviously, these girls are held down and struggling, wriggling. So the cutting will be just, in different ways and different scarring. And it's to stop that in the countries who have private medical clinics and medicals, they have been trying to do it to stop tetanus and bleeding. But that has been also not allowed. So this happens to girls aged 7, 10 and beyond, also an older woman or younger babies. I think this is lists of what happens in these different countries. For example, you can see in Eritrea, obviously there is more, but 50% of these women have some flesh removed. So for example, Eritrea has 9 ethnic groups. The 9 ethnic group practice different things. Like my ethnic group, we didn't do it on mine, but the other groups, they do from all these type 1 to 3. Mary will go through the types later on. Depending on your ethnic group, your village, that severity and minority will be just depending on that. And this is obviously, it's considered a human rights abuse, and the girls haven't given consent to practice this. And because of that, the long-term, short-term consequence is severe. Mary will go in detail with that later, but that has to stop. This has to stop because it's a human rights violation. It's biggest issue. And there is a legislation in many of the African countries, but that works or not depends on the government. I think there was one, as you can see, a military takeover and rules change in Africa, as you can see in Sudan, even currently. But even I'll give you an example. In Burkina Faso in 1984, this young army guy, 27-year-old Thomas Sankara, took over and said the first thing he wanted to eradicate was early child marriage and FGM. Then a year later, he was assassinated, and that was toppled. So it changed. But in Australia, we have a law. It's not one law we have. It's the same message and mission, but each state and territory has different messages and I think time of the law enforcement. It's illegal to take any child abroad, and the guardians are responsible for that, and the penalty is heavy. That's depending as state to state, as I said. But those people who take their children back home are responsible, because the grandmothers, others could do it. I can tell you one example. When I was in the Sudan in the early days, there was an English woman who was married to a Sudanese doctor also. She had an emergency, had left home to go back home from Sudan. And when she left the girls with the father and the housekeepers, grandmother came and did her girls. So that far, you know, it's still embedded issue. Now I'm going to let you, Marie, continue with that. Thank you very much.
Good evening, everyone. Thank you, Nagisti. I'm going to speak about the African Women's Clinic and what we actually do in the clinic. The FARAP team, which Nagisti leads, is a very important part of the African Women's Clinic. We work very closely together. Nagisti has said when the FARAP team was established, in 2010, we started the clinic, which is now called the African Women's Clinic, but in the early days was called the Defibrillation Clinic, which no one understood that terminology. So in 2015, it was renamed. The African Women's Clinic, of course, does not cover all women that are affected by FGM, but it was a name that was accepted by the executive, and I had lots of information from England and London, and that most of their clinics have the word African in them. Thanks, Nigisi. This is just a beautiful photo that I love to put up of women who are affected by FGM and the diversity of the women.
Oh, no. What happened?
Are the slides playing up?
Stuck. Sorry. Oh.
There we go. So in the African Women's Clinics, it's myself and Sarah, who you can see behind me with the blonde hair. We're the two nurse midwives that work in the clinic. We do have a third midwife as well who fills in casually for us. We are, as I said, very supported by the FARAP team. So the Ngisti is supported by Medina and Salekwa. We liaise with the pelvic floor unit, so they're our medical team. So if we have women that have any complications that we see that need assessment and even theatre, that's where they're referred to, and also women who need their defibrillation performed in theatre. In the 11 years we've been running, there haven't been many women at all, less than, I don't know, 10 or 11 that have needed to go to theatre. Most of them have had their defibrillation under local anaesthetic with either Sarah or myself. So going on to the types of FGM, FGM is, and I should talk about language, we talk about female genital mutilation, and when I'm speaking to health professionals, that's how I speak. In clinic, we usually use words like traditional cutting. And I think one of the big things about asking about a woman about what has happened to her, lots of people ask us, how do you actually ask that question? It can be as simply as, I see that you were born in Somalia. I know that traditional cutting does happen in Somalia. Have you been affected by this? The World Health Organization has classified FGM. As Nagisti said, these children are held down while they are having this cutting. As you can imagine, with no anaesthetic, there is lots of pain and they do move around a lot. So every woman we see is cut differently. There can be some, particularly with type 3, there can be some that look similar, but as our genitalia is different in every single person and the cutting is different depending on what the traditional cutter has actually done or been allowed to do or managed to do. In type 1, it's about the clitoris. So some women will talk about sooner, and sooner is when the clitoris has been cut. It may be completely cut or it may be a little bit cut. It just depends what's happened. The other types of FGM are type 2, 3 and 4. Type 2 involves the clitoris and the labia minora. So we see many variations of this. The clitoris might be removed, some of the labia majora, there might be one labia majora left, they might both be cut. Type 3 is really the type that most women that are affected have lots of complications. So type 3 is when The clitoris may or may not be cut, the labia minora may or may not be cut, and the labia majora have been sewn together with a small introitus left so that she can pass urine and menstruate. Most of the time, and in my 11 years of running this clinic, in 2 women, I have seen an anterior opening. So for whatever reason, the women had been sewn up and the introitus was anterior where the clitoris would have been. This, and when I always do the history first, obviously, before I examine a woman, and neither of these women thought this was unusual. They thought that they were passing urine normally, and obviously they were having complications of sorts, but they didn't actually realise that how difficult it was for them to actually be passing urine and menstruate. So usually there's a small posterior opening, but often too with the women, or not often, but many times, there will be little bridges of skin across the vagina. So what has happened is these women tell us that when they're having their cutting, they are told to keep still after. Often they have their legs bound together so that they will keep still and it will heal together. But the women will tell us that as a girl, they're the naughty ones that run around and still want to play with their friends, and it doesn't heal completely like as is expected. Type 4 is absolutely anything else. Piercing, cuttings, and even cauterization of the vagina with various herbs. Just to give you a bit of an idea of the referrals we've had, this was from 2010 to 2020. We are one of the few clinics at the women's that the women can self-refer, which was kept that way because it is such a personal thing for these women to be talking about. The link between the community and the clinic are the FARRP team. So they can ring the FARRP team Monday to Friday, they can leave a message, they'll always get back to them, and these women can seek out lots of information before they even make an appointment in our clinic. We see women from all over Victoria. They don't have to be in the catchment area of the women, so women of all ages, pregnant, non-pregnant women, women who come to us because they may have got married and having difficulties sexually, or they've become pregnant and they're worried how their FGM may affect their pregnancy. There's lots of different reasons why they come to us. Just giving you a bit of an idea of the age at first appointment. So those younger ones that you see, under 19, we actually have never performed a defibrillation on a woman under 18. They have all been older. The story behind these stats is we had an Australian woman bring in 4 girls that she had adopted, her and her husband had adopted, and it wasn't until the girls were older that she heard about FGM and she was really concerned. So she spoke to the girls and they all came into clinic, and by memory, 2 of them had type 1 FGM, but the others didn't. So that's why and we've had some other younger girls come in to be assessed as well. We've had some older women, which we can tell you some lovely stories. One particular comes to mind. We had an older woman who had been married, had 4 children, had 4 cesareans. She was getting remarried and had come to us because she actually wanted to have a more enjoyable sexual life, and that was why she came to us, which we thought was pretty exciting. By country, just you can have a look at the stats there. And as Nagisti said, we've had women come through that have been born in Australia. We still don't really have a lot of evidence here in Victoria of traditional cutting happening, but we certainly can't say for sure that it doesn't. So obviously the consequences of a child, a girl, having traditional cutting is very obvious to all of you clinicians. We have no idea how many girls die from it. The long-term, the scarring, the emotional and physical scarring, we see a lot of women who do have concerns in their sexual life. recently, in the last 12 months, we've had 2 women who have presented with cysts that have grown over the clitoral area. One actually we referred onto the pelvic floor unit, and she went to theatre and had over 100 mils drained out of this cyst. We see women who psychologically are having a lot of concerns, and we refer them on. We can refer on to anywhere in the women's, our mental health team, our psychosexual counselling, anywhere that is appropriate. And of course, the women who have had a caesarean section because when they've come to birth, the clinicians there haven't known how to do an anterior cut, a episiotomy, which is something that we're trying very hard to make sure that we educate our staff, particularly in this, because it still does happen. And of course, the other thing is too that we have women that when they come to us and they ask what actually has happened to them, they are terribly upset when they realise that they have a type 3 FGM particularly. Impacts on maternity care, of course, is a caesarean section, as I said, due to having cutting and not being identified antenatally, and staff not feeling skilled or being skilled enough to do an anterior cut in labour. Also, earlier on, we don't find it as much now, but earlier on, women were asking to be sutured after they'd had their babies, resutured. We had to explain that that was against the law. We don't hear that as much these days. In the clinic, we have a FARAP worker with us, but of course with COVID, we tend to do our consultations separately or via the phone. We just go through the usual general health status, then we get onto the reproductive health, try to, make it as comfortable as possible for them before we start asking about their traditional cutting. Some women do get upset and start having flashbacks. We will stop at that stage. These women can come back to the clinic as many times as they want to discuss what's happening. It doesn't have to all be in one appointment. And also we have the time. Our consultations might take an hour. If the woman does come in and she's pretty sure that she has a type 3 and she would like to be defibrillated on the day, then we are very happy to do it on the day. Sarah and I will always run our clinic over time if we have to, because we just feel it's really important for these women that, if they're feeling brave enough and they're in the right headspace, that it's really important that we do it when they want. Otherwise, they can come back 3 months later, they can come back and talk about it as many times as they want. And when they're ready, then we'll do their defibrillation. They have to be ready to have it done.
So I'm actually going to talk about how to support patients or clients, depending on what term you use, when they present in primary care. Obviously, we've heard that from Maria Nagisti that a lot of referrals come from GPs. So I'm hopefully going to just talk about some things that maybe we could do in primary care that can support people, obviously using resources such as FARAP and the African Women's Clinic as part of our management plan. But before we do that, I would just like to talk a little bit about some of the things we could do. So this is where I'm hoping my mouse will work. Yes. I'm going to talk about 2 cases. They are based, they're fictionalized, but they are based on clients who did present to me in just a normal consulting day. And so just to give you a sense of what sort of presentations might occur in family planning or primary care, and that's Salma and May. I am going to discuss some approaches to how you might discuss FGC or M in general practice. And I think it's really interesting when I was listening to Marie's talk that my opening question is the same as your opening question. And I think that just shows what a great opening question it really is and how useful it can be. I'm going to touch on some tips and tricks about sensitive examinations, which can be used for any sort of sensitive examinations, but of course are important when dealing with people who've had FGC. And that sort of touches a little bit on vulval examinations and talking a little bit about that. I'll talk about further management from a primary care point of view. I will highlight mandatory reporting. We've heard from Marie and Nagisti that it is illegal in Victoria to take a child or away to have female genital cutting or to perform that. So of course that does actually touch on our mandatory reporting requirements. And just summarise with some take-home messages that I hope will be useful for you. So I'm going to introduce Salma. Salma, the inspirations for Salma, attended to have a cervical screening was what Salma said she was looking for. I'll say that Salma's 28. She's never ever had cervical screening, and she does identify as a cisgender woman, meaning that she identifies with her birth sex and uses she, her pronouns. And she's actually been married for 3 years. And the reason she's come for cervical screening is because she'd really like to start a family soon, that she wants to come and get all the checks that she's been told are useful to get ready to get pregnant. And Salma was born in a country in the Horn of Africa and moved to Australia at age of 10. So I'd like you to interact with me. I'm gonna ask you to think back to Marie's slide on consequences. And I'm going to also think about in your own practice, what might be some of the issues for Salma? And I'm hoping that you might put those in the chat and we can actually use that to discuss together we're in primary care. What do we think might be some of the issues? It always takes a little bit of time as people type away. I can say that one of the issues I first thought about was if we've never had a cervical screening, how is that going to go for someone? What does she understand about cervical screening? What does she know about cervical screening? I'm hoping everyone's typing in chat because, Claire, nothing's sort of coming up to me at the moment. Oh, I'm so sorry, but I've just got a message that the chat is disabled. So Belinda, thank you very much for letting me know. But yes, definitely, what if we do a cervical screen, will there be pain or will there be difficulty with using a speculum? Absolutely. So it looks like, unfortunately, I'm not going to be able to have chat today, which is unfortunate.
That's okay. We're going to have a look into it, and hopefully for the next one, we'll be able to use the chat.
Right.
Apologies.
So we'll definitely use it for my next case. So I'll talk about some of the things that I was hoping that might come up. So one of the things I thought is one of the issues might be thinking about, we've talked about that Salma comes from a country in the Horn of Africa. Could female genital cutting be an issue for her? Are we actually thinking about that? We've talked about what does Salma know about the CST, pain or difficulty? What does antenatal care mean to Salma? Does she have any concerns about getting pregnant or being pregnant? What's her experience with people in her family who have been pregnant or delivered? Because often, what's happened to sisters or aunts or people that they might know in the community? And are there any problems with conceiving? Is that why Salma's actually come in? I will talk about it in the case in my next case about that there can be pain with post female genital cutting, but sometimes it can actually be difficulties with actually having any sort of penetrative sex, and people can be concerned that they know that that's how you get pregnant, and what if I can't get pregnant? And so there's lots of different things that might be an issue for Salma. The next slide that I had was actually thinking about some of the barriers to care. And I was really hoping that we might be able to talk a little bit about having time. In general practice, it is hard to have sensitive discussions with time, and it may be that some of these things might be needed to talk about over several appointments. Wanting to talk about language barriers and, you know, are we thinking about language barriers to talk about some of these topics and getting interpreters? And luckily with the telephone interpretation, it can be quite useful. You can call up on the day, but are the interpreters that you need available right then and there? Does the appointment need to be rebooked? Have we got cultural safety? Are we aware of what sort of things we might need, gender of practitioners, what's appropriate to that person? And someone's already mentioned, you know, one of the barriers might be discomfort and pain and not wanting to cause discomfort or pain. I guess the other thing is, you know, what understanding does Salma have? What health literacy does Salma have? What sort of information would Salma like and is useful? So I was going to go on to the next case. So I'm just wondering, Claire, is chat up and available? Because I was going to try and go through the same things of thinking about what are the issues and what are the barriers.
I've just been given the host privileges, so I'm just going to have a look at it now. There shouldn't be any issues with the chat that I can see, but please feel free to pop your answers in the Q&A if that's what you're able to do for the moment.
But I'm hoping everyone's thinking all these thoughts as I'm talking, and I'm hoping it's stimulating lots of thoughts. So I want to introduce May. So May is based on a real case, and I think we've already touched on that. You know, people were asking, well, what about people from other countries? And the inspiration for May actually came to see me, and May was originally from Malaysia. So this was so from a different country, but sort of thinking about the same sort of issues. The fictional May is 25 and once again identifies as a cisgender woman. Came to Australia when she was 14 with her family. And the reason May is presented is because she's actually having pain when trying to have sexual intercourse. May was married 6 months ago and hadn't been sexually active before marriage, wants to be sexually active, but is finding that she just can't, with her supportive partner, have any sort of penetration at all. And this is starting to impact on May's relationship. They're starting to become, though the partner's supportive, it's starting to become an issue. May doesn't want to be touched anymore. She doesn't want to, because things might lead to this, and she's feeling that every time she tries, it ends up in pain and discomfort, which is actually making her feel very down. The inspiration for May was very tearful when I met her, and this was something that was really weighing on her. And she said she actually was starting to feel not confident about her body. And I think one of the things that was a conversation starter for me is she said, I feel like something down there is not right. And I said, well, what do you mean by something down there? And that's where we started our discussion. So I would like you to sort of say to me, and chat is now available. So hopefully the last case has stimulated lots of thoughts so that we're ready to go now. What do you think some of the issues for May might be? Give you time to type. So while everybody's, yeah. So the first one, so one of the issues is, has May had female genital cutting? What kind of cutting? What sort of structures or shapes, or what feels comfortable? What's normal for her? Yeah, so that's a really interesting point. So someone said expectations around sex. So I guess, Belinda, if you'd love to elaborate on that, but I'm going to assume sort of things like, what is sex meant to be? Is sex always penetration? Is there other parts of intimacy? We've talked about the psychological effects. You know, having a good, fulfilling sexual life doesn't always mean penetration, but it is about what is comfortable and what is wanted by that person. And that can then impact on your quality of life. It is one of the things about your quality of life. Absolutely. Yep, fear with regards to pain at penetration, and also what am I going to say as the doctor about, you know, what should May do? Am I going to be supportive? Or am I going to say, oh, well, that's just the way it is? I hope I wouldn't say that, but, you know, yes, maybe she's worried about what I'm going to say. I think some of the things are very similar to Salma, which is language, you know, what sort of relationship, language, am I being culturally safe? Time, I mean, we're talking about pain. We're also maybe talking about cutting and what that means to May. We're also talking about relationships, mental health, body image. So that's a lot in one appointment. And I guess most of the time this is not going to be one appointment, and that's okay. And absolutely, one of the issues might be, will this lead to relationship breakdown? And what does that mean for May for her security, for her, how she feels about herself, and how, you know, what's in her community if she had a relation breakdown, what family or structures or supports might she lose? Thank you. Thank you very much, everyone. So I've already talked a little bit about barriers, but are there any other barriers that you think might be an issue, specifically talking about sex and relationships with someone? Hoping everyone's madly typing, but I'd like people to think, well, how do they feel about talking about sex, and especially sexual practices? Yeah, embarrassment, absolutely. We know some of the barriers is embarrassment on both sides. People want to be asked, but it is something that can feel a bit uncomfortable to talk about sex life and sexual practices. It can be uncomfortable for clinicians if they don't want to cause offence or embarrassment. Religion, yeah, beliefs. What's May's beliefs around sex? What's her religious beliefs around sex? Absolutely. About gender roles, marriage. Thank you. So they're all really useful. So I'm going to move on now, and what I'm going to do is I'm going to talk about a bit of a suggested approach that you can use. And I think the first thing to reflect on is that we have skills that we can use in this area. We have skills in history taking. People do take sexual personal histories during general practice care. We've got sensitive examination skills. Anytime we do a breast check or a genital check, or anything that requires somebody to disrobe, so skin checks, things like that. So we've got those skills. It's also, we can use vulval examination skills, which is looking at skin and shape and structure, and observational examination skills. And if you are interested in upskilling in vulval examination, I do have some links and resources at the end of my talk to build on the examination, the gynecological examination skills you might already have. And as part of primary care, we do supportive gynecological examinations when we do cervical screening, when we do antenatal care or postnatal care. So we can use those skills when we're supporting people with female genital cutting. So when we're talking about a sensitive examination approach, it is important to gain trust and to discuss confidentiality. This is a topic where people may want to feel private, want to feel safe, want to feel secure. I often find when I'm doing a sexual history that if I signpost that I'm going to ask questions, it can be really helpful to let people prepare. So I might say, can I ask you about what you said about that you're having painful sex? Or can I ask you a little bit about your vulva and about how things feel? Can I ask you about your sexual history and sexual practices? I find normalizing really helps as well. I always ask about if you're having any sexual pain when I talk about cervical screens, or is it okay if I ask you a question about your sexual health? And I find that then you can layer those questions. You know, you might say sexual health, and you might say, as part of sexual health, do you ever get sexual pain? Do you ever get sexual pain with certain positions? Have you got any concerns or worry? And I find that that can be really helpful. I always give people permission to stop, or to not just give me the whole story if they're not feeling ready today. And I let them know that if they're not feeling comfortable to talk about something, they just have to say, I'd rather stop there, or I'd rather not talk about that, or maybe I'll talk about that at another time. Once again, I talked about languages, and I think Marie also talked about that. Getting interpreters. It's really important to have independent interpreters, so that a professional interpreter, so that you're actually making sure that we're talking about these areas with good language skills and to help support informed understanding. And you don't want to use family members, and also need to really think about if a specific gender is preferred by the person. You'll see here that I've got some words in italics. These are from the health pathway that Ella will talk about, all about supporting people with female genital cutting. So you can see there that there is this resource that can really remind you about some of these points about being sensitive to the discussion, building up trust, and using those skills that you've got for other sensitive histories and examinations. So how do we want to talk about female genital cutting? Because one of the things is we're talking about our signposts, we're talking about sexual health, but we want to have the skills to actually ask. And so, as I said, I've got the same question. I find it works really well. You know, if you do get from the history that someone is from these areas where female genital cutting is working, and you've asked, you know, I want to ask you about this, you've signposted it, I find asking this question is very straightforward. And so there are many countries around the world where female circumcision or traditional cutting is used or practiced. Has this happened to you? And that really opens to have that discussion. If you feel that you haven't quite got to that point, some questions that can lead to that question is, do you have any concerns about this screening or getting pregnant? Have you had any difficulties with it before? I often ask about tampons or any sort of examination, anything that has been around the opening of the genitals, the introitus, that can often help you jump into that question. And asking the person, what do they think is causing the pain or problem? As I said, the person that I've fictionalized said to me, I think there's something wrong down there. And that was a really opening question for me. So, well, what do you think's wrong down there? And once again, I thought was a really good point. I've really adapted into my practice. This comes from the pathway that Ella's going to talk about. Is I thought it was really important, I hadn't thought about this, that to stress to the patient that though it's illegal to perform FGM in Australia or take someone away, it is not illegal to have had FGM. I thought it was a very interesting point that some people who are not as up to date with Australian systems, you know, they might be just new to the country, are really worried that if they do tell you this, it might affect their refugee status or they might be deported. And I thought, and I've really taken that on board to be very open about, you know, I've got mandatory reporting if it's going to happen, but if it's happened, I'm here to support you. That's not illegal. We mentioned it's a sensitive examination. I guess my one tip about sensitive examination is it's really important always to discuss not just the examination, but why we're doing it. I was training in IUDs yesterday, and there was a very good point about we were doing a vaginal examination, and it wasn't just saying this is what we're going to do, we're going to use our finger, we're going to put our hand, but why we were doing it. And we were explaining that we're doing it because we need to know this to put in the IUD safely. So I think it's really, it is that not only just letting people know what's going to happen, but why you're doing what you're doing. You do need to consider your terms and the level of information the person wants. And once again, a fantastic tip from the pathway is be aware that it may be the patient's first experience of the Australian medical system at all. And it may, not just that, it may actually be the first sensitive or gynecological examination anyone's had. So it is something to take slow. Examination may be difficult, painful, or completely impossible. And that can happen for female genital cutting or a range of vulval conditions where it might be that you don't do a full examination, you don't do a digital examination, you don't do a cervical screening, but you can stage it as it's needed throughout somebody's care. I let people know that I'm going to be observing the vulva, looking at the skin, because it can be a little bit disconcerting if someone's standing at the end of the bed, and they're wondering, well, why are you standing? But you're actually looking and doing active observation, always talking about gentle palpation. And if there is actual vulval or sexual pain, consider doing a cotton tip test to document pain. You can use the jumbo swabs, or you can just use little cotton tips. Here's my cotton tip that I brought. because it's not, it can be, it's obviously soft, and then it's not as uncomfortable until you can get to a point which is painful. So I then document areas where the cotton tip doesn't feel soft anymore, because there can be secondary vulval pain or vaginismus following any sort of cutting or any sort of changes or trauma to the vulva. And obviously don't persevere if uncomfortable or painful, and letting the person know that if they say stop or I need a breather, that you will stop and give a breather. And I really give words to use so that we're on the same page. If you are doing cervical screening, sometimes using local anaesthetic can help with speculum examinations. Some clinics do have local anaesthetic sprays. We use it when we're putting in intrauterine devices, so we have it in the clinic, but it can be bought for the clinic. It does take 3 minutes to work, where you spray it on the opening, the introitus, or anywhere that's uncomfortable. Or there can be ointment and jelly, which can be bought over the counter. A cheap version is to use the Soothe hemorrhoid cream. So that's an option if people can't get the xylocaine ointment. But that does need to be put on 30 to 60 minutes prior to examination. Do warn people that it can sting initially. So I've had words like spicy, prickly. The best one I heard was it felt like a really warm peppermint. And so just do warn people, but it's only for about 20 to 30 seconds, and then it will numb the area. Using small speculum, very careful angulation of instruments, or you might even support the person to insert the speculum themselves, gives them a lot of control, and then together then you can take over to actually do the examination, and trying to use single digit examination as required. Very important that if you do any examination to document what you have examined and what you've seen in detail, because it minimises the need for repeat examinations, and also will let further practitioners know if you need to do something different for the next examination, or if catheterization problems can be anticipated for. Well, what about further management? I think it's worth thinking about what screening is actually needed for the person in front of you. If you need to do sexually transmitted infections, this can be done by first pass urine or self-taken swabs. We do not always need to use a speculum or a vaginal swab. And for cervical screening tests, the person might be eligible for a self-taken now. But since I've done these slides, I actually had to run in and update it, because as of July 2022, self-taken cervical screening tests will be available for everyone. But if someone is eligible now, so that they are under-screened, then that can be an option instead of having to use a speculum. Do people need sexual counselling? Marie has discussed how through the African Women Clinic, they can be referred to the psychosexual clinic. There are private sexual counselling, but cost and access is always an issue. There is Rosie King, who is an Australian author who has written books. The one that mainly gets a giggle is, you probably won't be able to see that, Where Did My Libido Go? But it does require, you have to think about language and whether it's appropriate language. Does someone need to be referred for vulval pain or pain management? And of course, I often refer to African Women's Clinic, and in fact, I think I always refer to for an African Women's Clinic. And of course, gynecology and obstetric referrals as needed. Just want to once again touch on mandatory notification, which is very important for healthcare practitioners. We've said it multiple times that the performance or removal of a child from Victoria for this procedure is strictly prohibited, and health practitioners are required to report concerns about possible FGM if they think the child is in danger. So it's mandatory reporting under the belief of reasonable grounds that a child needs protection. So that is something that does need to be thought about when you are talking to someone, talking to them about their family. So that's just something to consider. I did talk about Rosie King, but there are lots of translated resources. So on the health translation website, I've got the cervical screening one up there. It's in lots of different languages, including African languages and Asian languages. But there are actually sheets on there about sexual health, sexual pain and relationships. So that's quite a good resource. These are the resources I use. My slides will be available, you don't need to know these or write these down. I do use the Cancer Victoria Cervical Screening Information Card that does support the kind of questions we've been talking about. Obviously, the Royal Women's, CoHealth has quite a good website, as does some of the healthcare from the West. We have some resources as well, mainly around the research and some of the policy documents. And Ella's going to tell you all about the excellent resource that's now on Health Pathways Melbourne. As I said in my slides, but I'll mention it now, if you are interested in upskilling, specifically in vulval examination, having a, feeling like you've got skills in vulval examination does help you to support examination for people with female genital cutting. We have a vulval course, and Jean House has a lot of webinars, especially about supporting you to use language and how to ask about vulval concerns or sexual concerns. So my take-home message is the key question to ask yourself when working with someone who might present for screening or antenatal care or who have come from countries of prevalence of female genital cutting is this person likely to have come from that country? My favourite suggested opening question, there are many countries around the world where this is practiced. Has that happened to you? Consider if it's going to impact on any of your sexual and reproductive health examinations, such as cervical screening, sexual health. Think about in relationship or mental health issues, and specifically antenatal or postnatal care. And as practitioners, we do need to consider our mandatory reporting requirements. Thank you very much.
Thank you, Dr. Sarah. That was a wonderful presentation. There is one question. So if anyone else does have any questions, pop them in the Q&A. Now, I think, Nagisti, I don't know if you wanted to answer this one or Sarah, but this one's going back to the African Women's Clinic. Do your referrals need Medicare?
That's a good one. If they have, it's great. If they don't have, they can come and still will manage taking them through.
Thank you. I do encourage, if anyone has any questions for Dr. Sarah, we can get to them towards the end of the presentation as well. But yeah, wonderful presentation, and I know everyone will really appreciate the tips and really practical things that we can do in general practice to help women. Now I'd like to hand over to Dr. Ella, who will take us through Health Pathways and how to navigate the website for this particular topic, and some exciting news about its recent launch.
Thank you. Just trying to get everything up here. Hopefully, can you guys see my screen?
Yep,
Yes,
that looks good.
Awesome. Thank you to everyone tonight. It's been really informative. I am one of the clinical editors at Health Pathways Melbourne, as mentioned, and we just thought we'd take this opportunity tonight to share this page on FGM or FGC, which is hot off the press. It's just gone live literally overnight, and all the speakers tonight were involved in reviewing the page. So it's been just a great opportunity to show you guys around the page a little bit. For those people that haven't used Health Pathways before, essentially it's a platform to help clinicians at the point of care by providing kind of locally agreed information to help make the right decision for the patient with the patient in front of you. The pathways are designed to be used during the consultation, and they're really aimed to provide concise guidance for assessing and managing patients with particular symptoms or conditions, and referral information for those conditions. The content is developed collaboratively by GPs, by hospital clinicians, and by other health professionals, and it is evidence informed, but also I think importantly it reflects local reality, which is what makes it so practical and so useful. If you haven't used Health Pathways before, this is how to access it. So it's melbourne.communityhealthpathways.org. You do need to email the team if you don't have a login. So emailing info@healthpathwaysmelbourne.org.au, and you will be provided with a profession-specific login. which will get you to this home page, and then you just type it into the search bar, which takes us to our page on FGM, FGC. Most of the clinical pages, or many of the clinical pages, have a background information section, an assessment section, a management section, and referral, and then some resources both for clinicians and for patients. So we just thought I'd just show you a couple of sections from this particular page, much of which obviously was discussed tonight. So you can see in the background section here just some information again about some definitions, about some terminology, and again about some of those legal aspects here in Australia. Moving on to the assessment section, you can see that there's lots of drop-down menus to really open up and just get to the bits that you need quickly. So you can see here just accessing the types of FGC. And then again, as we've discussed over the course of the evening, some questions, just if you kind of forget those questions, I think they've been drummed into us tonight, but really how to get onto the topic and ask these questions sensitively to open the discussion. As Sarah's really eloquently put it, she's given us already lots of tips and tricks, but there's also some here as a drop down as well. So things to make it a little bit more comfortable for your patient, as well as a link to that Cancer Council Victoria document that Sarah mentioned, which is some tips and tricks related specifically to cervical screening in women who've been affected by FGC. So clicking on that link will take you directly to that document. Two-page document, as I said, really handy thing to have access to. The management section looks a little bit more at some of the referral pathways, so the African Women's Clinic and the FARET program, of course, as we've talked about, as well as managing some more specific situations, such as the defibrillation. So you can see the African Women's Clinic, there's a bit of information there, and again, a link to take you directly to the Royal Women's Hospital page. Same goes for the FARET program as well. So there's again another direct link, so you can get all the information you need at the click of a button, as well as some information about defibrillation and what they do at the clinic, as Marie has spoken about tonight. The referral section again links out to those referral options, but again some links here about mandatory reporting, and also for women with psychological or psychosexual concerns, there's some referral options there that they can follow through as well. Many of these resources Sarah's mentioned, so I know it's good we're on the same page. So these are all obviously just links at the bottom of the page. CoHealth have made a wonderful video about talking to your patients about FGC, so that's that top hit there. The family planning guidelines and the Royal Women's Hospital guidelines have lots of useful information. And there are some multi-language resources which are really useful for patients available via NETFA, as well as the handouts from the Royal Women's Hospital, of course, as well. As always, we'd love to get your feedback, so please feedback any comments or suggestions on the page. You can do that by just clicking on that little chat icon in the bottom right-hand corner of the page, and that will come to us, or by emailing the Health Pathways team, as mentioned before. Health Pathways exists across the country and across the world, but they are localised, obviously. So what we're looking at tonight is Health Pathways Melbourne. There are other regions around the state. If anyone's listening from out of town, you're very welcome to contact the Melbourne team to get access to this page tonight if you need. Thank you, everyone. Just again, those links and contact details for you. Thanks, everyone.
Thank you, Dr. Allah. That was wonderful and very comprehensive for the new health pathway, which is exciting that it just launched overnight. I'll give a couple of minutes for anyone that has any questions, because we do have a bit of time now. And if any of the speakers wanted to add anything in, please feel free to jump off mute if there's anything you'd like to add. I do really thank all the attendees for coming tonight. I know that there's a lot of things going on at the moment, but it's wonderful to have you here and to learn a bit more about the FGM and how to talk to patients and in the community about it. I will ask our backend support to pop the evaluation survey link in the chat as well. And you know, when you have some time at the end of the session, we do really appreciate all your feedback, and I know all the speakers here do as well. So that will be popped in the chat soon, and will also be sent in a follow-up email with the recording and the slides. So yeah, as Dr. Sarah had mentioned, don't need to take down all the resources. We can send that to you. And any future events that you'd like to register for and attend, you can visit our website, northwesternmelbournepHN.com. I don't see any extra questions in the Q&A or the chat, so we might leave it there. But yeah, unless anyone else wanted to make any final comments. No? We'll have a couple minutes to spare for the evening, but yeah, do thank all the speakers for your time tonight. It's been such a wonderful presentation and really comprehensive on the topic, you know, going from the background and the cultural side to the African Women's Clinic and how to talk to people in the community in the health pathway. It's been a pleasure facilitating for you all. So thank you everyone. And